Fluid, electrolyte, and acid-base balance. Fluid, electrolyte, and acid-base balances within the body are necessary to maintain health and function in all body systems. Intake and output of water and electrolytes, distribution in the body, and regulation of renal and pulmonary function all help contribute to homeostasis. Nurses have to monitor imbalances which result from many factors, including illnesses, altered fluid intake, or prolonged episodes of vomiting or diarrhea, just to name a few. Interstitial fluids are the fluids between the cells and outside the blood vessels. Intravascular fluid is blood plasma that's found in the vascular system. And transcellular fluid is separated from other fluids by a cellular barrier and consists of cerebrospinal, pleural, gastrointestinal, intraocular, peritoneal, and synovial fluids. Table 41.1 will help identify electrolytes and their normal values. Osmosis attempts to equalize concentration of molecules or ions on both sides of the membrane. Osmotic pressure is the drawing power of water and depends on the number of molecules that's in a solution. The pressure of the solution is called osmolality. Osmolarity is another term that describes the concentration of the solutions. Diffusion is affected by molecular size, concentration, and the temperature of a solution. The difference between two concentrations is known as the concentration gradient. In the process of filtration, hydrostatic pressure differences determine the movement of water. With increased hydrostatic pressure on the venous side of the capillary bed, edema is going to occur. Active transport is enhanced by carrier molecules within a cell that bind themselves to incoming molecules. Fluids and electrolytes shift from compartment to compartment, which are separated by cell walls and capillary membranes. Solutions are classified as hypertonic, isotonic, and hypotonic. Isotonic solutions have the same osmolarity as blood, like normal saline or 0.9% sodium chloride. A hypertonic solution, such as 3% sodium chloride, is going to pull fluid from the cells, causing them to shrink. A hypotonic solution, such as 0.45% or 1/2 normal saline, moves fluids into the cells and it will cause them to enlarge. The regulation of body fluids is done by three main parts: fluid intake, hormonal, and fluid output. With fluid intake, the hypothalamus is stimulated when excessive fluid is lost through vomiting, hemorrhage, diarrhea, etc. With hormonal, we have changes in the renal perfusion that initiates the renin, angiotensin, and aldosterone mechanism. Renin is secreted by the kidneys and responds to decreased renal perfusion. It helps produce angiotensin 1, which is then converted to angiotensin 2, and angiotensin 2 is a vasoconstrictor, and it helps improve renal perfusion by increasing blood flow to kidneys. Angiotensin 2 also stimulates a release of aldosterone when sodium concentration is low. Aldosterone will then increase the reabsorption of sodium and water and the secretion of potassium and hydrogen. The antidiuretic hormone, or ADH, is stored in the posterior pituitary and is released when there are changes in blood osmolarity. It helps prevent diuresis, causing the body to save water. I mean, it's right there in the name, antidiuretic hormone. The ADH also works on the renal tubules and collecting ducts to help return water to the systemic circulation. Excuse me. The atrial natriuretic peptide is secreted from the atrial cells of the heart in response to atrial stretching and an increase in circulating blood volume. It inhibits aldosterone by increasing sodium and water excretion. In fluid output, about 180 liters of plasma is filtered through the kidneys on a daily basis. It helps produce about 1,200 to 1,500 mLs of urine. When we look at insensible water loss, this is water loss that is not visible, and it occurs through the skin and lungs. Sensible water loss, on the other hand, is perspiration, expiration, and urination. We also have about 100 mLs on a daily basis that's excreted in feces. Regulating electrolytes. Well, we have the two different types. We have cations and anions. Sodium is the most abundant cation in extracellular fluid, about 90%. It's needed to maintain and or regulate water balance, nerve impulse transmission, acid-base balance, and cellular chemical reactions. The concentration is normally 135 to 145 milliequivalents per liter. Potassium is the principal cation in the extracellular compartment. It's necessary for glycogen deposits in the liver and skeletal muscle, transmission and conduction of nerve impulses, cardiac conduction, and smooth and skeletal contraction. The normal range is 3.5 to 5.0 milliequivalents per liter. Calcium is stored in the bone, plasma, and body cells. 90% of calcium is located in the bone and 1% in the extracellular fluid. Approximately 50% of calcium is bound to protein or albumin, and about 40% is free ionized. The normal serum level is 8.5 to 10.5 milligrams per deciliter. Calcium is necessary for bone and teeth formation, blood clotting, hormone secretion, cell membrane integrity, cardiac conduction, transmission of nerve impulses, and muscle contractions. Magnesium is essential for enzyme activities, neurochemical activities, and cardiac and skeletal excitability. About 50 to 60% of magnesium is found in the bone and 1% in extracellular fluid. Normal lab value ranges from 1.5 to 2.5 milliequivalents per liter. In anions, chloride is the major anion in extracellular fluid. Chloride always follows sodium. Chloride is regulated through dietary intake and the kidneys. The normal values range from 95 to 105 milliequivalents per liter. Bicarbonate or bicarb is the major chemical base buffer in the body. It's found in extracellular fluid and intracellular fluid. The kidneys are what regulate bicarbonate. The arterial levels range from 22 to 26 milliequivalents per liter, and the venous or the carbon dioxide content is 24 to 30 milliequivalents per liter. And phosphorus. It exists in the form of phosphate, and it's found in intracellular fluid with a small amount in extracellular fluid. It assists in acid-base balances. Phosphate and calcium help to develop and maintain bones and teeth. They're inversely proportional, so as one rises, the other will fall. So if calcium rises, phosphate is falling. If phosphate is rising, calcium is falling. The normal level is 2.8 to 4.5 milligrams per deciliter. For optimal cell function, the body maintains a balance between acids and bases through three processes: acid production, acid buffering, and acid secretion. Normal acid-base balance is maintained with acid excretion equal to acid production. The chemical regulation of the carbonic acid and bicarbonate buffer system adjusts within seconds to change the pH of the extracellular fluid. If you have a low pH, that is equivalent to acidosis. A high pH is equivalent to alkalosis. Biological reactions occur immediately after chemical reactions. Two physiological buffers in the body are the lungs and the kidneys. The lungs are the body's primary control of the excretion of carbon dioxide that results from metabolism, so it helps with metabolic acidosis. The lungs adapt to acid-base imbalances to return the pH to normal before biological buffers kick in. So in other words, breathing will increase or breathing will slow down. With metabolic acidosis, the respirations are going to increase, causing an increase in exhaled carbon dioxide, which decreases the acid level. With metabolic alkalosis, the lungs are going to retain carbon dioxide by decreasing respirations, and this increases the acid levels. The kidneys, on the other hand, control excretion of hydrogen and bicarbonate ions, and it helps with respiratory acidosis. Now, I know this sounds weird. The lungs help with metabolic, the kidneys help with respiratory. The kidneys will take a few hours to several days to regulate acid-base imbalances. When they do respond to acid-base imbalances, they increase or decrease bicarbonate production. And these are some of the disturbances that we may see with electrolyte and fluid and acid-base balances when things aren't working right. Isotonic deficit and excess exist when water and electrolytes are gained or lost in equal proportions, but osmolality remains unchanged. Osmolar imbalances or losses or excesses of water that affect concentration or the osmolality of the serum. You need to be familiar with blood gas values, and I have these listed here for you on your slide. Respiratory acidosis will occur when the PaCO2, excess of carbonic acid, and a low pH of 7.35 is below 7.35. Respiratory alkalosis will occur with a decrease in PaCO2 and an elevation in pH, or it's above 7.45. Metabolic acidosis is a result of a high I'm not sure what that is. High ID content and loss of sodium bicarbonate. So I'm not sure what the ID is. Okay, metabolic alkalosis results from the loss of acid from the body or an increase in the level of bicarbonate. Most common causes of that are vomiting and gastric suctioning. Prolonged or severe compromises can lead to irreversible or chronic health problems. Over time, the body's adaptive compensatory mechanisms can no longer maintain fluid and electrolyte or acid-base balances. Signs and symptoms of hydration imbalances, some of the causes can be disease processes, medications, diarrhea, nausea, vomiting, side effects from procedures or treatments, and hemorrhage. Symptoms can include low blood pressure and postural hypotension, thirst, edema, sudden weight loss or weight gain, depending on if you're dehydrated or overhydrated, tachycardia with dehydration, dark yellow urine with dehydration, or very dilute urine with overhydration. But sometimes it can be dark also with overhydration if the kidneys are not working appropriately. Dry mucous membranes, poor skin turgor, poor urine output, confusion, cold clammy skin, furrows in the tongue with dehydration, slow vein filling with dehydration, or very full bounding pulses with overhydration, crackles in the lungs with overhydration, flushed skin, fever, restlessness, agitation, coma, seizures, lethargy, weakness, and a change in the level of consciousness. Gathering information during the assessment process is going to help the nurse identify problems that the client is experiencing. All of these areas can give clues as to the client's condition. You need to be very aware of relevant past medical history, illnesses, burns, respiratory disorders, head injuries, cancer, cardiovascular disease, renal disorders, and GI disorders as you're doing your assessment history. With the physical assessment, your daily weights are going to be one of your best indicators of your fluid status, as is intake and output. Measuring I&O at 24-hour intervals will give an overall status of fluid balances. Usually these measurements are done on a shift-by-shift basis, but we look at the totals at the 24-hour interval. Some of the laboratory studies are also very beneficial in assessing physical status. They can include serum and urine electrolytes, hematocrit, blood creatinine, BUN, specific gravity of the urine, and ABGs. As you're doing your nursing diagnosis and planning, realize again that multiple body systems can be involved, and make sure you use your NANDA-approved list of nursing diagnoses. When you're setting your goals and outcomes, set your priorities. The client's clinical condition is going to determine which diagnoses have the highest priority. If the client's medical condition is not dealt with in a timely manner, fluid, electrolyte, and acid-base balances can get worse. You need to question, why is the client under or overhydrated? With older adults, for example, they don't like to urinate all the time, so they don't drink as much as they should. Or maybe they're on diuretics and they just don't drink as much as they should because they don't want to be in the bathroom all the time. They may not know how much fluid is required. Some clients may have gastrointestinal issues that prevent an adequate fluid intake. Overheating or profuse diaphoresis, again coupled with an inadequate intake to compensate for the fluid loss. Inadequate output can cause overhydration. So then we look at collaborative care. It may involve other services, including discharge planning, nutritional support, and pharmacy. Determine the client's fluid preference and supply those fluids to help improve intake. Also offer assistance with fluid intake and increase foods that have a high fluid content. Other tips that were gone over in the nutritional aspect can help increase or improve fluid intake with clients. Also those that have the swallowing issues, using some of those same tips to improve fluid intake. Infants and children need to replace fluids when vomiting or diarrhea occur, and we need to educate parents of this. Adults, especially the elderly and infirm, need to replace fluids when increased perspiration occurs. With enteral replacement, oral replacements may be contraindicated if the client is vomiting or they have a GI tract obstruction or they're at risk for obstruction or have impaired swallowing. Those enteral replacements with oral fluids and electrolytes are indicated for clients that can drink. We also restrict fluids. If a client has a fluid volume excess, they need fluid restrictions. Or maybe they have an electrolyte imbalance, like a really low sodium, so they're hyponatremic. We may also institute fluid restrictions. These clients may have chronic illnesses such as chronic heart failure or renal dialysis. Parenteral replacement of fluids includes TPN, crystalloids, and colloids, such as blood and blood components. TPN is an abbreviation for total parenteral nutrition. And it consists of a hypertonic solution containing glucose, electrolytes, and other nutrients that are delivered through a central IV. With IV therapy, we have to look at vascular access devices. There's catheters, cannulas, or infusion ports that are designed for repetitive access to the vascular system. The peripherally inserted catheters are going to be those that are for short therapy, such as fluid restoration postoperatively and antibiotic use. Long-term use is going to be your central line or your PICC line or implanted ports. You need to be familiar with your IV solutions. The isotonic solutions are going to have the same osmolality as body fluids. The hypotonic solutions are those that have less osmolality than body fluids, and hypertonic solutions have a greater osmolality than body fluids. When IV therapy is initiated, you have to have the appropriate equipment, and we're not going to go into detail at this point, but just so you are familiar with the process. Venipuncture will be commonly performed in the hand and the arm. We have to understand that the young, elderly, and frail have very fragile veins. IVs are not inserted into an area that has signs of infection, infiltration, or thrombosis. We have to regulate fluid, and we do that through gravity, through control or regulator pumps, and electronic infusion devices. We monitor the fluid flow to help prevent over or under infusion. As we maintain the system, we do that through replacement of IV bags, tubing or dressing changes, and connections, changing the connection devices through and according to hospital policy and protocol. With the central IV line, when it's in place for parenteral nutrition, again, placement has to be confirmed with an X-ray. There's three things that are of the utmost importance with IV therapy. The entire system has to remain sterile. When you're changing solutions, bags, and site dressings, it has to remain sterile. You also need to assist the client with self-care so they don't disrupt the integrity or sterility of the system. Complications of IV therapy include swelling at the site, pallor, and coolness at the site. Phlebitis is an inflammation of the vein, and fluid volume excess occurs when the fluid is administered too rapidly. The purpose of blood replacement is to increase the circulating volume after surgery, trauma, or hemorrhage, to increase the number of red blood cells and to maintain hemoglobin levels, and to provide replacement therapy of clotting factors, platelets, or albumin. Blood is grouped into types. We have A, B, O, and AB. Excuse me. Then we look at the RH, which is the positives and the negatives. If blood is mismatched, a transfusion reaction will occur. Blood transfusions can be autologous, which is technically the patient's own blood, and it's planned before surgery, for example. When transfusions are not planned, then blood will come from a bank of stored blood. Specific blood tubing has to be used to prevent hemolysis or blood breakdown. Transfusion reactions. When a transfusion reaction does occur, immediately stop the blood transfusion. Remove the tubing all the way down to the IV hub, flush the hub with normal saline, and then follow facility protocol, which will include monitoring the client, notifying the provider, and usually obtaining urine and blood specimens. And evaluation. Again, if no progress has been made, the nurse needs to change interventions to help the clients meet their goals or outcomes.